When it comes to women with bleeding disorders, I am sure everyone is familiar with Dr. Paula James from Kingston General Hospital. Her presentation is entitled Von Willebrand's Disease Guidelines, How Can Patients Use Them? Please welcome Dr. James.
Thanks so much for having me today. It's my pleasure to present in a session on women and bleeding disorders, a topic that's very near and dear to my heart, and it was fun actually to go back and think about the VWD Guidelines, which we published in 2021 in light of this presentation. So these are my disclosures. So I have two objectives for this morning. The first is to discuss the contribution of patient experts to the development of the 2021 VWD Guidelines, and then to describe the impact of the VWD Guidelines on the provision of care for people with VWD. And I'm going to focus on the dissemination and implementation activities that have taken place since the guidelines were published. So as this audience is well aware, VWD is the most common inherited bleeding disorder. It's diagnostically challenging. It's caused by decreased VWF levels or a problem with the function of von Willebrand factor. We see mucocutaneous bleeding predominantly, but we can also see musculoskeletal bleeding, so bleeding into muscles and joints in more severe cases. And without a doubt, VWD is understudied. And so a number of years ago, there were many organizations who all around the same time realized that a concerted effort to try to put together an international VWD guideline would have value. This was a statement put out by the National Hemophilia Foundation about the need for a qualified, relevant organization to put together an evidence-based clinical practice guideline. So NHF certainly was involved in this, as were a number of other organizations. Similar discussions were happening within ASH, the American Society of Hematology, and also within ISTH. And so, happily, those partner organizations joined forces and decided to work together rather than separately working on their own guidelines. And the decision was made to have two panels, one focused on VWD diagnosis and one focused on management. And importantly, the priorities that we set to include recommendations on were set by the community. And that happened in 2016, 2017, 2018. And so there was an international scoping survey that was done by many of the people who were involved in leading the guidelines. This was publicized through all of the partner organizations at all of the meetings that were happening around that time. And these were the responses that we got. And basically, these responses set what questions we focused on to make recommendations for the guideline. So you can see that the input came from 71 countries, from 601 participants. And I can't see, there we go, blue. The blue dots are patients or caregivers, and the orange dots are healthcare providers. So you can see that at least half of the input was coming from patients and their families. 21% of the respondents were male, 54% female. There was some representation from low and middle income countries, although most came from high income countries. And so based on the data that we got from this scoping survey, we set out the PICO questions that we were going to address in the guideline. There was international panel membership that included patients, and so the patients ended up on the panels because they were nominated by the partner organizations. That was the same actually for the clinical and the scientific experts that were involved as well. All of us were vetted very carefully for conflicts, and the management of conflicts dictated the way we behaved for many years, actually, when we were involved in this guideline. There were 7 patients involved in both panels. They had a range of VWD types. There was wide geographic representation, and they were full voting members. So they were at the table, the same as the clinicians and the scientists. ASH was the lead organization on the process, and they hired an external consultant to provide patient education. The chairs were also trained on how best to engage with patient experts through a process like this. We held multiple meetings with the patients to make sure they understood the importance of their voice, to be sure that they would feel comfortable speaking up, and to be sure that they understand what the process looked like. Staff from all of the partner organizations attended all of the meetings, and so all of the in-person meetings that we had, there were representation from the patient organizations in the room as well. So the work was about 5 years and culminated with 2 key publications that were published in Blood Advances in early 2021. And so these are the 2 main papers. These are widely available online. There were 9 additional papers that we published as part of the project. And so each of the recommendations that we did had a systematic review. Many had a meta-analysis that informed the recommendations, and all of that was published separately as well. And so I want to give you an example of what the patient voice did in terms of the recommendations we made. So this is recommendation 6. This is the recommendation that looks at VWF cutoff values for the diagnosis of type 1 VWD. We knew going in this was going to be a very important recommendation. It was something that had been debated and had been controversial in the past. And so the recommendation that we made was that for patients with an abnormal initial VWD screen and suspected type 1 VWD, the cutoff level of a VWF level of less than 0.30 or 30%, that equals type 1 VWD, full stop. If the levels were between 30 and 50 and there was abnormal, that also should be diagnosed as type 1 VWD. And what had led up to this was that group of patients being called low VWF, which biologically might make sense, but actually unintentionally was a barrier to care, particularly in places where having a clear diagnosis then opened up access to medications like tranexamic acid or desmopressin. The strength of the recommendation is, this is a strong recommendation. There actually are only 3 strong recommendations in the entire, for the entire process, largely because the quality of evidence that we have for VWD is lacking or poor quality. And that was the same for the data that existed for this recommendation. There was data, but it was not the highest quality. And despite that, we made a strong recommendation. And that was because of the patients on the panel who told us that the way things were was not good enough, and that people who were bleeding were being denied access to care. And that was a huge guiding principle for all of the voting that we did. And so we ended up with what's called a discordant recommendation, which means that on low quality evidence, we made a strong recommendation. I've, in many rooms, justified this decision, and I can tell you that as time passes, I'm actually very proud of what we did here. This is not usual for a guideline, and as I said, 100% was because of the patients in the room who told us the kind of suffering that they had experienced or they had seen their family members experience, and they wanted this guideline to prevent that from happening in the future. And so the clear priority was not to miss a diagnosis and to ensure access to care. There also definitely is a flavor of equity with this recommendation. A group of people who would suffer significantly with levels between 30 and 50 from not having a clear diagnosis are predominantly women with heavy menstrual bleeding. And so we wanted to be sure that those patients had access to care. So shifting gears then to show you what's happened since we published the guidelines, there's actually been a lot of activities to raise awareness. Press releases, campaigns on social media, video interviews with panelists. And so many things have come out to try to make people aware of the guidelines. We had a discussion with the CDC in the States about the ICD codes that are used in the US to diagnose VWD, and we got them changed to line up with the current classification of VWD. We also created patient toolkits and workshops, and there are plans in place and underway being led by NHF to develop patient decision aids to help make decisions about what might be best for a particular patient, shared decision-making in the instances where we don't have strong recommendations, particularly for management. This is what we did with the ICD codes. I mean, it's still a mess. VWD diagnosis is complicated as hell. It honestly was way worse than this before we got our hands on it. There are toolkits that are available and that can be accessed that line up with the guideline recommendations. And so in terms of how I think patients can use the guidelines, I hope you would feel assured that the patient voice was critical in the recommendations that we made. I think it's useful to be aware of them as a tool to advocate for care, understand the limitations. The quality of evidence is poor when it comes to VWD, and I think the patient organizations and patients themselves can really continue to push for high-quality VWD research so that we can make stronger recommendations across the board as time goes. And just in my last minute, I want to just let you know about a project that grew out of the guidelines and really grew out of the recognition of the poor quality of evidence. And this is a project called Core VWD. This is an important next step because of the poor quality evidence. And this is a Delphi project that's just getting rolling to determine a core set of patient-important outcomes for VWD pivotal and post-approval clinical trials. This is a multi-stakeholder project. It includes patients, of course. And we patterned this on Core Heme, which Alfonso Iorio led a number of years ago and created a core set of outcomes for gene therapy trials in hemophilia. Core outcome sets are useful because when clinical trials don't measure the same thing, it gets quite difficult to compare them. But if you have a minimal set of things that every clinical trial has to address, number of bleeds, ferritin, for example, quality of life, you start to build a stronger evidence base on which to make recommendations. There are a number of ways people can get involved. I was just having a chat with Sarah Ford. We definitely need more patients to be involved in the focus groups, and that's really to help us derive the initial set of outcomes that then we will vote on subsequently. There are opportunities for patients and clinicians to get involved as panelists, and we've just finalized the advisory board, which includes Sarah from the CHS. So if you're interested in this, feel free to grab me, and I'm happy to have a chat about it. Elizabeth Clearfield is leading the project, and Mark Skinner, who I know is presenting this afternoon. I'm not sure if Mark's here at the moment, but Mark will be here today, and him and I are co-leading this project, and we'd be delighted to chat about it. So I just want to acknowledge the staff from all of the organizations who helped me put the slides together, and then all of the people who were involved in the guidelines. Thanks for your attention.